Welcome to Pulse&Pressors, where critical care gets crystal clear. Cisatracurium is the preferred paralytic for ARDS, ECMO, and multi-organ failure because it is metabolized without reliance on the liver or kidneys. It is stable, predictable, and safe in the sickest patients. Unlike depolarizing agents, it does not produce fasciculations and releases almost no histamine. These features make it ideal for prolonged control of mechanical ventilation in severe critical illness. Cisatracurium acts as a competitive antagonist at nicotinic acetylcholine receptors. It prevents acetylcholine from binding, producing flaccid paralysis without depolarizing the muscle membrane. This mechanism avoids the potassium shifts, fasciculations, and dangerous depolarization physiology associated with succinylcholine. Hoffman elimination is the defining feature of Cisatracurium. It breaks down spontaneously based on pH and temperature. Alkalosis and hyperthermia accelerate its clearance. Acidosis and hypothermia slow it markedly. This gives the drug a unique predictability in patients with impaired organ function. Because clearance does not rely on hepatic or renal pathways, it remains stable even in multi-organ failure. A major advantage in ARDS and ECMO, where organ dysfunction is common. Metabolism occurs through the Hoffman reaction, followed by secondary ester hydrolysis. The absence of active metabolites makes Cisatracurium safer for long infusions. Its elimination depends purely on physiochemical conditions rather than hepatic blood flow or renal function. This organ-independent clearance is why Cisatracurium is consistently recommended for severe ARDS and ECMO sedation paralysis strategies. Cisatracurium has a moderate onset of 2 to 3 minutes and a duration of about an hour. Its onset is reliable, but not as fast as rocuronium or succinylcholine. However, its duration and recovery curve remain consistent even during shock, sepsis, and multi-organ failure, allowing precise control during prolonged mechanical ventilation. Compared to Atracurium, Cisatracurium causes far less histamine release and is better tolerated in unstable patients. Atracurium's metabolite Laudanosine accumulates with prolonged infusion and may contribute to seizures. Cisatracurium produces much less Laudanosine and is therefore safer for long-term paralysis, which is frequently required in ECMO and severe ARDS. Intubating doses range from 0.15 to 0.2 milligrams per kilogram, with maintenance boluses around 0.03 milligrams per kilogram, and infusion rates from 1 to 3 micrograms per kilogram per minute. Because metabolism depends on pH and temperature, clinicians must adjust dosing during hypothermia, severe acidosis, or alkalosis. These adjustments are especially important during targeted temperature management or ECMO runs. Cisatracurium excels in ARDS protocols, ECMO initiation, and ventilatory desynchrony because it provides smooth, predictable paralysis without accumulation. It is particularly effective during post-cardiac arrest hypothermia when renal and hepatic drug clearance is impaired. Its stability across changing physiology gives clinicians complete control during the most delicate phases of respiratory support. This drug does not cause fasciculations. Side effects are minimal and include rare hypotension or mild histamine effects. Laudanosine accumulation is possible, but significantly less concerning than with Atracurium. Seizures occur only when levels become extremely high during very prolonged infusions. In ECMO and ARDS protocols, this risk remains extremely low due to Cisatracurium's clean metabolism. Aminoglycosides, magnesium, and beta blockers potentiate Cisatracurium, increasing blockade. Chronic anticonvulsant use increases receptor turnover, creating resistance. Acid-base changes and temperature shifts modify metabolism and duration. These interactions matter significantly in complex intensive care unit patients on multiple medications. Cisatracurium is reversed with neostigmine and glycopyrrolate. Sugammadex does not reverse benzylosoquinolineium paralytics. Because Cisatracurium undergoes predictable spontaneous breakdown, many clinicians rely on natural recovery rather than pharmacologic reversal, guided by train-of-4 monitoring. In hepatic or renal failure, Cisatracurium's independence from organ clearance makes it uniquely reliable. Shock states and severe metabolic derangements minimally affect its pharmacokinetics. It accumulates less than other paralytics during prolonged infusions, making it ideal for sedation paralysis strategies. These properties make it the preferred paralytic during ECMO and severe ARDS, where organ failure is common and unpredictable drug accumulation is dangerous. This drug is the paralytic of choice for severe ARDS, requiring ventilator rest, ECMO cannulation, CT surgery desynchrony, and refractory bronchospasm with ventilatory conflict. It performs reliably, even in the most extreme physiologic environments, and gives clinicians full control over ventilation when it matters most. Cisatracurium's stability, organ-independent elimination, and low histamine release make it the most dependable paralytic in the ICU. It is foundational for ARDS protocols, ECMO support, and prolonged paralysis strategies. When physiology is unstable, Cisatracurium is the safest and most predictable choice. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.